Yeah, when you see neck patients, how often do you think, let's flip it around. When you see patients that have got headaches, how often do you think that a lot of that is coming from their neck, whether that is posture, whether that is an actual cervical radiculopathy, a pinched nerve, or some other kind of myofascial problem? How often do you think headaches are really influenced by neck issues?
You know, I will tell you, it took me a little bit from a Regenerative standpoint to be able to get a better understanding of how things are interconnected. Originally by training, we are very discrete in nature, and I don't mean to typecast any specialty, but for pain, traditionally, we would think about neck for a lot of things because those are things that we can do, right? If you see many neurologists, they may think about intracranial pathology. So what that means is that, is it coming from the brain? Is there a structure that's maybe more ominous that has some other issues that might be causing that headache? But I think at the end of the day, what we really have to do is kind of take this to a much broader scope. And that's one of the ways that we practice now, is to say, okay, if it's head pain, maybe it's coming from the neck. If it's the neck, maybe it's coming from a higher source or a lower source, and really evaluate all those things in full. So that's really the approach now, to be able to make sure that we can give a good outcome and that we can get a good assessment.
I think it's interesting because I hear what you're saying. I know when I first started in practice or through my training, it was much more your problem is X. And as I've sort of progressively gotten more and more involved in regenerative medicine, understanding concepts like prolotherapy and biotensegrity, and realizing that just how many layers of tissue are involved in the musculoskeletal system, and how segment to segment are really influence each other, it's interesting because it really changes your perspective on the musculoskeletal system, and it makes you realize just how interrelated the top of the spine to the bottom of the spine really is. And someone who's got a headache and they've got a little bit of asymmetry in their hips or their ankles, like how much does that affect their neck and their head? Like it's profoundly more significant. And I think for physicians, a lot of times we don't necessarily get trained in that regard, but that's obviously an important aspect of how to approach someone with musculoskeletal issues, in particular neck and head. And you made a really good point, which is that physicians look at these things very differently. They have a very different approach. A neurologist maybe focus more on intracranial pathology or vascular kind of issue causing headaches. And it's a very different approach, and it can be right in some people, but not always right in other people. And it's sometimes hard, I think, for patients to really understand that medicine is not always such a cut and dried approach, that there's a lot more layers involved in this. And it's probably hard for people to really get a sense for, hey, what is Dr. Landrum's approach to treating neck pain or headaches? But that's probably vastly different than maybe somebody else that they could see for neck pain. And if I had to put you on the spot and said, define for me Orlando Landrum's approach to treating spine-related issues in like that 2 to 3 sentence kind of package that kind of really hits home for how patients and other people should sort of think about your approach. Give me that sense.
It's a darn good question. This should be spread beyond Facebook and Instagram for that kind of question. So, all right, let's see. 2 to 3 sentences. To me, I think at the end of the day, what I want to make sure that we do in terms of treatment and evaluation is, number one, we rule out serious pathology that's going to make sure that you can be able to have peace of mind and that there's not going to be harm that befalls you. Number two is I want to make sure that your pain and functionality improves through whatever treatment we need to do in order to get there. And I would say, in terms of the evaluative process, I think that I use a blend of both musculoskeletal and neurologic evaluation, and then we pair that as needed with imaging to be able to get some clarity about how we're going to treat and intervene.
Okay, so tell me more about neck pain and headaches. I think headaches are a humongous problem in society, And a lot of times they're just treated with that sort of pharmaceutical approach that typically helps more with just either masking pain or sort of vascular related pain. Give me your approach to how you're looking at headaches, if they are related to any of those peripheral nerves that are coming from the neck or from the neck itself.
Yeah, so I think your commentary about headaches are spot on, because traditionally, the way that we try and treat many problems, particularly when they have a pain focus, is to say, what medicine can we give? And I think that that has a number of flaws, as we've kind of talked about in our conversation already, because to kind of maybe not use a Cajun analogy, but to go a different way that's describing this similar perspective, it's not a portfolio that you want to have. But to me, it's kind of almost like you have a portfolio of things that present themselves. Meaning, so you don't just have one problem, but you have a multiple different problems that might exist, and they're different percentages that you have invested in different areas, right? So it could be that you have a disc, you have a facet, and then you have an occipital nerve problem that all contribute towards your problem. The question is what can you impact the most in order to be able to get the best return, right? So when we talk about going to headaches and such, it's really convoluted, or at least it can be. And I think that first and foremost, it has to be where the physician and patient feel comfortable to be able to talk freely. And I know that sounds like a lot of fluff, but for me, I don't think that's the case at all, because headaches has a whole host of connotations that are associated with it, where people feel like there's a bit of malingering. Or, are you really having a headache? How bad can it be? I'm sure it's not that debilitating. Maybe you just need to be a little bit more stoic, or you just need to kind of suck it up a little bit. And particularly when you've been to more than one doc, sometimes you kind of feel like, man, I don't want to be a complainer. I don't want to be a whiner. And right from the very beginning, we want to toss it out the door. We need for you to be able to feel like you're comfortable in order to explain what's going on with you, so that we can really get down to the nuanced piece of like, what's the challenge that is bothering you or that's annoying you, and how can we tease that out to be able to get a better understanding about things.
Yeah, that
So
makes a lot of sense. Go ahead. Sorry.
that's all right. So when we talk about looking at headaches, there's a huge component that can be everything from us. Number one, is there an intracranial issue, which more than likely is not the case, to the most common being, is it tension type headache, where you have a muscular imbalance that's causing you some problems and issues. That can come from the neck and come from the head, right? Could it be an occipital neuralgia type issue, where you have nerves that are present in the back of the head and neck that really are giving you a problem with pain type sensation that goes from the back of the head over to the front? Is it a cluster phenomenon, where you have an issue where you have a problem with the aspect of the eye, which is classically described as like an ice pick, where you have just this lancinating, burning pain that's present within the context of the eye? Could it be coming from something like trigeminal neuralgia? Could it be coming from something like sphenopalatine issues? Things where there are foci and collections of nerves that exist in the cranial nerve component that exists in and around the skull that we can be able to treat. So those are things that are kind of the quote unquote common things, but there are other elements that could be in place. Are we looking at a dental issue? Could you have bruxism, where you really have a bad fit with how your teeth are, and you kind of chew or grind at night, and you really need to kind of see what's going on with the jaw? Do you have TMJ as a potential option and potential issue? So all of those things really need to be kind of evaluated in full, and then said, where do they fit in that portfolio? What's the percentage of where they're at, based on history, physical, as well as the likelihood of debilitation, and then say, how can we be able to intervene?
When it comes to using an orthobiologic treatment, how do you like to treat some of those little pinched nerves in around the head, in the peripheral area? How do you like to treat those?
Sure. So I'm going to go backwards to come forwards. So I will tell you, by traditional training, the things that we would do before is to do all diagnostic, like we talked about before, right? The problem with doing a diagnostic blockade is that we expect that there's going to be complete obliteration, so that we can pat ourselves on the back and say, hey, you know what? We gave local anesthetic. It's better. This was the area. But first of all, maybe the area that you gave whatever that fluid wasn't as specific as what you thought. How did you evaluate it? Did you use ultrasound to be able to give that injection, or did you do it blindly? And I think having had the experience and exposure now to be able to see how refined and exacting you can really be with ultrasound is giving me a different perspective of, let's see where we're injecting and making sure exactly what we give goes to the spot where we need for it to go. So that's one. But two, I would say traditional pain treatment would say, let's do neuromodulation. Let's think about doing maybe peripheral stem. Let's think about doing spinal cord stem and see how those nerves can be able to respond. But again, if I had my druthers and it was me, and it was a family member, what I want to say is, can't we correct the nerve and get it back to the way that it was before we talk about adding another stimulus to try to change it? So the things that we use currently in order to be able to do this is something like platelet lysate, where we can be able to say, how can we give an injectate that's really going to give a good response to that nerve, get that nerve back to a functional status of how it was originally, and get it back to not only giving you the sensory information, but hopefully it acting in concert with things that work from a functional standpoint.